When most of us think about orthodontics, braces, we picture the end game. Teenagers, maybe adults, getting these fixed appliances put on to correct something that's, well, already a problem. We focus so much on the correction.
Right, the reactive part.
Exactly. But what about the before? What about all that critical early preventative work that can save months, maybe years, and definitely thousands of dollars in really complex treatment down the road? Today, we're doing a deep dive into just that, preventative and interceptive orthodontics. We're going to uncover the dentist's early warning system. We're talking about specific narrow windows of time where a really simple technique can completely change a child's future dental health. Our mission is to pinpoint those critical intervention points and explain why just monitoring a child's mouth, really between the ages of 3 and 12, is the whole foundation for their lifelong oral structure.
Okay, let's unpack this. So
Yeah.
before we get into the checklist and the specific tools, we really need to understand the philosophy here. Our research lays out this framework built on 3 crucial levels of prevention. And that framework is absolutely essential. I mean, for you, the learner, it clarifies who is supposed to be doing what and when. When we talk about preventing malocclusion, which is really just a fancy term for a bad bite, we're working on 3 very distinct levels. The first one is the primary level. That's preventative orthodontics.
Okay.
Think of it as proactive maintenance. It's all about oral health promotion. The goal is to stop malocclusion before it even gets a chance to happen.
So this is really early on.
Oh, yeah. This is happening while the child still has their primary teeth, or maybe a mix of primary and permanent teeth.
So we're talking about things like general dental habits, diet, early monitoring, just guiding things naturally from day one.
Exactly. Then you move up a step to the secondary level, which we call interceptive orthodontics.
Interceptive, okay.
And this is where things get really interesting, because now you're talking about early diagnosis and prompt treatment of unfavorable features. You see a problem starting to form, and you jump in to stop it from getting worse.
So the goal isn't a perfect fix at this stage.
Not at all. It's about facilitation. It's about making the final treatment, which will now be much less intensive, way easier down the line. This is mainly during that mixed dentition phase. And then finally, you have the tertiary level. This is the one everyone knows. Comprehensive orthodontics.
The full set of braces.
That's it. The full treatment, fixed appliances, the works. It's all aimed at preventing complications after the malocclusion is already there. But for today, we're really focused on those first 2, primary and secondary, where a tiny fix can have a huge result.
Right, where you get the most bang for your buck, so to speak. So if that's the goal, maximizing results through prevention, what does a general dentist actually need to be looking for? It's got to be more than just checking for cavities.
It's so much more. Our sources call the dentist a growth and development detective, which I think is a perfect description.
I like that.
The absolute core skill is understanding normal dentofacial growth patterns. You know, how the jaws are supposed to expand, how the teeth should fit, and seeing that the permanent set is kind of hiding just beneath the surface, waiting for its turn. The dentist has to spot those little deviations early, like a permanent tooth that's taking way too long to come in that might signal something is blocking it. Maybe an extra tooth, a supernumerary tooth, is in the way.
Okay, that brings us to the timeline, the chronological checkpoints that the research flagged. For you, the learner, who wants that clear what happens when, this is it. Let's start super early. Between the ages of 3 and 6 years, the dentist is mainly monitoring for normal interdental spacing. Why is that early space so important?
It's crucial, because if those little primary teeth are already packed in tight, it's almost a guarantee that the permanent teeth, which are much, much larger, are going to be crowded later on.
Ah, I see.
You want to see natural spaces between those baby teeth. They're sometimes called primate spaces. They're there to accommodate the much bigger teeth that are coming. If you don't see those spaces, you know a crowding problem is basically waiting in the wings.
Okay, so then we move into that huge transition phase, 6 to 8 years old. The focus seems to shift dramatically here.
It does. Now they're actively looking for potential crowding of the new permanent incisors, checking for things like an anterior crossbite. This is a big one. Watching for the ectopic eruption of the 6.
And the 6s.
The first permanent molar. It's the cornerstone of the adult bite, erupts right around 6 years old. If it comes in at the wrong angle, too far forward, it can literally start eating away at the tooth in front of it, the second primary molar.
Wow.
It's one of those time-sensitive specific problems the dentist has to catch. We're definitely going to dive deeper into that one later.
Absolutely. So the timeline continues 8 to 10 years. Now we're assessing space for unerupted teeth, the 3, 4, and 5. For those of us who haven't memorized the dental chart, what are the 3s, 4s, and 5s?
So those are the canines and the premolars.
And why are they so critical at this stage? Are they the ones that are most likely to get, like, jammed up?
They absolutely are. The canines, the 3s, they come in late and they need a lot of room. And the premolars, the 4s and 5s, are replacing those really bulky primary molars. This whole phase is about making sure there's enough space for these late arrivals. A dentist has to check the position of the upper canines with x-rays to make sure they're coming down properly, not, aimed to get stuck up in the jaw. That's impaction, and it's a major complication when there's not enough room.
And then finally, 10 to 12 years is just monitoring that they all arrive successfully.
Pretty much.
So you have this timeline based on what's erupting, but the sources also really stress that the dentist has to be a behavioral monitor too.
Precisely. They have to record any harmful oral habits. Things like, chronic thumb sucking past a certain age, tongue thrusting, lip habits.
These seem like small things.
They seem small. But these behaviors are what we call etiological factors. They literally apply forces that move teeth and can shape the jaw in a bad way. They can lead directly to malocclusion.
So if a dentist sees one of these problems, structural or behavioral, how do they know when to pull the trigger and intervene versus, just waiting it out?
If that ability to differentiate is everything, it's the key skill.
Why is that?
Well, if you intervene too early on something the mouth was going to fix on its own, you've just wasted time and money. But if you wait when you should have acted, the liability risk, the risk of creating a much more complex orthodontic case is huge. The real skill is recognizing those few conditions that are guaranteed to get worse without help. For instance, if a primary tooth is just sitting there and the permanent tooth is clearly erupting behind it toward the palate,
You've got to get the obstacle out of the way.
immediately. You remove the primary tooth to give the permanent one a fighting chance to drift into the right spot.
That strategic clearing of the path, that really is what defines preventive care. It's not about doing full-on orthodontics early. It's about these little micro-interventions at just the right moment.
And that leads us perfectly into the 6 main conditions our research highlights. These are the specific scenarios where a general dentist really needs to act, or at least consult an orthodontist right away.
Okay, let's start with the first one.
Condition 1, retained deciduous teeth. We just touched on it. But the consequences can be pretty severe if a primary tooth is ankylosed.
Fused to the bone?
Exactly, fused to the bone, and it's not moving. It won't just cause the new permanent tooth to come in crooked. Over time, it can actually stop the development of the alveolar bone in that area. You end up with a structural deficiency.
Wow. Okay, this second one, poor restorative attention. Seems so simple, but it sounds like it has huge architectural consequences.
It really does. It's not just about filling the cavity. It's about the quality of the filling.
What do you mean?
When a primary molar in the back gets a cavity and it's filled, that tooth has to be restored to its exact original shape. If the filling is just flat, or if the contact point with the next tooth isn't right, the teeth behind it will start to shift forward.
Oh, into that tiny bit of new space.
Yes, and that leads directly to a loss of space in the back of the mouth.
Yeah.
You've compromised the entire arch form just because a filling wasn't contoured correctly to meet its neighbor.
So a poorly done filling isn't a localized problem. It literally changes the geometry of the developing bite.
Exactly. Which brings us to the third, and maybe the most crucial concept here. Condition 3, premature loss of primary posterior teeth. Our research uses this fantastic term. It calls the primary teeth the natural space maintainers.
That's perfect. It just clarifies their purpose immediately. They're not just disposable baby teeth.
Not at all. They guide the entire eruption sequence. If you lose one of those primary teeth too early, say from bad decay or an accident, the consequences for the adult structure are immediate and, frankly, disastrous.
It's a chain reaction.
A complete chain reaction. Neighboring teeth tilt and drift into the void. You get crowding right there. Potential impactions for the teeth still under the gums, and even a shift in the dental midline. Losing that one temporary structure basically guarantees you'll need complex ortho in later.
The temporary structure has permanent and expensive consequences. What about actual bite problems?
Condition 4, crossbites. An anterior crossbite is when the upper front teeth are stuck behind the lower front teeth when you bite down.
Right.
Now, the data here has a key nuance. If the crossbite is only happening in a mouth with only primary teeth, you generally wait.
Why is that?
because treating it that early often doesn't guarantee it'll be corrected in the permanent set anyway.
But if it's an individual permanent tooth coming in wrong?
Then the intervention can be really simple. If it's just one or two teeth, you can often fix it with a simple appliance, like a bite plane, that uses the patient's own biting forces to push the tooth into the right position. Low-intensity, high-impact fixes. And the last two conditions are condition 5, supernumerary teeth, those extra teeth blocking the path, and condition 6, which is the ectopic eruption of the first permanent molars. That one needs a deep dive all its own.
Here's where it gets really interesting. Let's focus right in on that. Condition 6. The ectopic eruption of the first permanent molars, the sixes. This specific issue is just a perfect demonstration of how precise the timing has to be and why those x-rays at age 5 or 6 are non-negotiable.
Yeah, the core problem is that the first permanent molar is just. It's erupting too far forward, too measly, and it starts causing actual mechanical damage to the primary tooth right next to it. It's like a new building trying to occupy the foundation of an old building at the same time.
And the data says this happens in about 3% of the population, which, sounds small, but if you miss it, you're guaranteeing years of complex, expensive treatment.
That's right. And our sources know boys are affected a bit more than girls, and it's usually the upper molars.
The need for early diagnosis is so critical because often the first sign is actually a complication. The child starts complaining of neuralgic pain.
Right, and that pain isn't just from pressure. It's a failure of the body's barrier system.
Can you break down what that means simply?
Sure. As that permanent molar starts to eat away at the root of the primary molar, a process called resorption, it can break the epithelial attachment. That's the seal at the gum line.
A gateway opens up.
It opens a doorway. Oral fluids, bacteria, they all get into the inner part of that primary tooth, which leads directly to an infection and inflammation of the pulp. If that happens, well, you've lost the primary molar. It has to come out.
So what started as just a positioning issue becomes a race against infection and premature tooth loss.
Precisely. The good news is about 2/3 of these cases are actually self-limiting. They fix themselves with natural growth. But that other 1/3, they absolutely require correction and fast.
And this is where we get to that brilliant, specific intervention from the source material, the brass separating wire. This sounds so simple, almost too simple.
It's ingenious. It's a low-tech, high-impact fix for when that permanent molar is just partially erupted. It leverages the stiffness of the wire against the forces of growth.
So how does it work?
Well, the dentist uses a very fine brass wire, maybe 0.5 or 0.6 millimeters thick. They make sure the area is numb, and then they carefully thread that wire under the contact point between the erupting permanent molar and the primary molar it's stuck against.
Okay, so the wire is in place. What happens when it's tightened?
When they twist it tight, cut it short, and tuck it in, that wire acts like a tiny, powerful spring. It exerts this constant, gentle pressure that causes what we call dento-occlusal movement.
So it's pushing the tooth back and down?
Exactly. It's pushing the permanent molar slightly backward and slightly down, just redirecting its path into the proper position. The key is you have to monitor it. The wire has to be retightened every 2 or 3 days to keep the force going. It's a beautifully simple mechanical adjustment.
That really is the epitome of interception. Minimal effort for maximum redirection. But what if they catch it too late? What if that primary molar is already really damaged?
Then the treatment plan shifts dramatically. It's a whole different ballgame.
Right.
If the primary molar is too damaged, it has to be extracted.
Yeah.
But you can't just leave that space open.
Because everything will drift.
Everything will drift.
Yeah.
So first, you have to build an active appliance like a retainer with springs or screws to physically push that first permanent molar back into its correct position. Only after it's in the right spot can you put in a passive space maintainer to hold it there until the other permanent teeth arrive.
So you go from a 5-minute procedure with a piece of brass wire to a complex active appliance, then a passive one. It just reinforces why that early diagnosis back in that 6 to 8-year-old window is so incredibly vital.
So what does this all mean? At the end of the day, for you, the learner or the parent, or even the healthcare professional, the knowledge here really reinforces a fundamental principle. Preventive orthodontics is mostly about strategic inaction, and then precise, tiny interventions at very narrow moments in time.
We're not talking about major surgery.
Not at all. We're talking about extracting one retained tooth, or using a small, simple bite plane, or applying a single piece of brass wire. These minimal interventions, often done by a general dentist, are the insurance policy. They're designed to completely eliminate the need for complex, time-consuming, and expensive treatment later on.
It's really about appreciating the delicacy of this whole dental choreography. The role is less about fixing damage and more about being an expert guide, just making sure all the natural forces play out correctly.
And that guidance depends completely on appreciating the importance of what is temporary. We spent a lot of time defining those primary teeth as natural space maintainers. They're temporary structures that are the architectural guides for the entire adult mouth. And considering that, it makes you ask, right? How often in life do we underestimate the permanent consequences of temporary structures? Whether it's something like early childhood education or planning a city's infrastructure or even our own foundational investment strategies, we so often treat the temporary phase as disposable. We think we can fix it later, only to find out that the entire adult structure has been compromised from the very beginning. It's a profound thought, and it's definitely something worth mulling over.